Welcome to Heart of the Matter podcast. I'm Chris O'Connor, Principal Investigator of the Heart Failure Collaboratory, and we're continue our series on looking on how we can improve the ecosystem of research in the heart failure arena. And today's topic is looking at some of the recent decisions that have been made by the FDA and the advisory committees that support advice to the FDA around three different programs: the TOPCAT spironolactone in HFpEF program, PARAGON-HF, which looked at sacubitril valsartan in patients with preserved ejection fraction, and the most recent advisory committee review of omecamtiv mecarbil, which a drug being developed for patients with heart failure and reduced ejection fraction. And we're going to start at the top with TOPCAT, but I first want to introduce our distinguished panel today, and starting with JoAnn Lindenfeld.
Hi, I'm JoAnn Lindenfeld. I'm a heart failure cardiologist at Vanderbilt University.
Thank you, JoAnn. Peter Carson.
I'm currently retired, but I've been a heart failure cardiologist at the Washington VA Medical Center, and I am currently in Rehoboth Beach, Delaware, and I sometimes host our moderator, Chris O'Connor, down here. That's all I'll say.
That was benign this time. John Teerlink.
Thanks, Chris. I'm John Teerlink. I'm at the San Francisco VA Medical Center as a heart failure physician, and also very honored to be the president of the Heart Failure Society of America this year.
Thank you, John. Orly?
I am Orly Vardeny, and I'm a pharmacist, and I'm located at the Minneapolis VA and University of Minnesota.
And Bill Abraham.
Yeah, hi, Bill Abraham, professor of medicine at The Ohio State University, heart failure cardiologist and clinical trialist.
Thank you, Bill. Well, in December 2020, we had two interesting reviews by the advisory committee to the FDA, to the cardiorenal panel. And the first one was the TOPCAT trial, a trial with spironolactone in patients with heart failure and preserved ejection fraction. And this was really an analysis of this trial and whether the label could be expanded for spironolactone in patients with heart failure, indicated in patients with heart failure and reduced ejection fraction. And I may ask Peter to jump in and comment on, the advisory committee voted in favor 8-4, but there was a lot of split feelings about whether the one trial was robust enough to change the indication. And was there enough supporting evidence? And was that trial, did it have too many problems to be a standalone? So I'll start, Peter, with you and say, what are your thoughts? You've been involved in this space for a long time.
Well, thank you, Chris. I was recused out of that meeting, unfortunately, but I would have voted against the indication, expanding the indication, and for a number of reasons. One thing we often say is that trials get kind of points for style, so to speak. They're well done, they're well designed, et cetera. And for me, TOPCAT doesn't really fit that. And the particular protocol problem was in what was described as Stratum 1, which allowed patients to get in with what is described as a hospitalization within 12 months, in which heart failure was a major component. It is not what we usually find in history of heart failure hospitalization as a criteria for entry, where it is the primary reason for heart failure. So this opened the door, particularly in Eastern Europe, to the enrollment of patients who ended up having a remarkably low event rate, and there was little benefit of spironolactone to be found, and that was half the trial. There was a lot of question about this, what was going on in Georgia and Russia with the enrollment of these patients. It came to the Data Monitoring Board, and They indicated that they ended up thinking that a lot of these patients were ischemic heart disease because of the leniency of the definition for entry. So this this took away the ability of the trial to be favorable on its primary endpoint, if it would have been. And one is left then with this mixed up subgroups, really, where it's hard to tell where spironolactone works and where it doesn't, and how you would label it. So, for example, do you label it and say that it's for patients in whom natriuretic peptides were elevated, but they do not have a previous hospitalization for heart failure where it is an important part of the admission or the management? How do you do that? And then finally, at the end, with a whole bunch of conflicting signals regarding that group, including in the US, not just in Eastern Europe, you're then left with the issue that the drug is usable in the United States in patients. Patients won't be denied this therapy. And since most HFpEF patients have hypertension, one could reasonably use this drug without expanding the indication. So I would have voted against it, and for the issues that I just elaborated on.
Well, you're a tough guy, and I'd like to hear from other members of the panel, because you do a large outcome study. You have a large subgroup that stands alone called North America. The interaction p-value is highly significant. There's enough events in that group to be a standalone trial. And yet you can't seem to move and find that's enough evidence. JoAnn?
Well, I agree with Peter.
I never know how to predict JoAnn's responses.
This has made my day.
10 years lesson as the senior associate editor at Jack. I never can predict JoAnn's responses.
Well, first, I think the Europeans say, if I'm correct, that the test of interaction for that, moving out of Georgia, moving those patients out was not positive. So while it seemed like a very good story, I believe the interaction test for the patients in Georgia versus others was
That's
not
correct.
statistically significant. So that to me posed a problem. And I just think that while I'm sympathetic and I believe it probably works, this is one trial whose primary endpoint was negative. And so I would sort of side with Peter on this.
Okay. Orly, you know a fair amount about this trial. Dr. Pfeffer and Dr. Solomon were heavily involved in this study. I think they would feel differently than Dr. Lindenfeld and Carson.
Well, I think the issue is much more nuanced, because while we have a neutral study with a non-statistically significant p-value, we know that there were regional variations in study conduct. So I feel like it's difficult to dismiss, and therefore thinking about the totality of evidence, especially when it comes to some of the secondary analyses of the groups or individuals with an EF that was closer to 40%. So in that mildly reduced ejection fraction, in addition to the post hoc, but still analyses showing that there was likely non-adherence to study medication, not just the wrong patients, but probably participants not actually taking the therapy. So that, in combination with some of the post hoc analyses, makes me uneasy to dismiss it completely. So I have a difficult time, but I would push back against both JoAnn and Peter on this.
So in this exercise, you have to vote yes or no or abstain.
Yes or no for an
expanded indication of
I will vote
spironolactone.
yes.
Okay, good. Bill, you're hearing some of your colleagues here roll in. When we do the AdCom, there's not a Bayesian influence of the previous votes, so we'll have to do this differently on round two. But what are your thoughts here? I mean, obviously, if what I would say is if we had the right monitoring and surveillance structure, remember this was an NIH trial, these two countries may have been like how we treat sites that aren't adherent or violate inclusion-exclusion criteria. We remove them from the analytical data set before the database is locked.
Yeah, I think that's right, Chris. And, I do think that this is one of the limitations of NIH-funded studies, is that there are a lot of things that one can't do to really rigorously monitor sites during the conduct of the trial. And we generally, only surface these issues after the trial is completed. And in many ways, it penalizes those studies. There's been a lot of discussion, as you're quite aware, at the NIH about the plethora of negative studies, sponsored by NIH in the cardiovascular arena. There are a few positive ones, but there are more negative than positive ones. And I think part of it is, relates to some of these issues around execution. But coming back to TOPCAT, I think, Orly has stated the position quite well. I think it is much more nuanced. I don't think that trials should live or die by their primary endpoint, but really a look at the totality of evidence, understanding the study, understanding its execution, looking at the evidence, looking in particular at, in this case, I think some of those secondary endpoints. There seems to be a robust signal for a reduction in heart failure hospitalization in these patients. And, there are other studies of spironolactone used in the setting of HFpEF that have suggested improvements in exercise capacity and functional status and quality of life. And when I think about this from a risk-benefit standpoint, in a population of patients for whom there is little GDMT available, now we've got emerging sacubitril valsartan and certainly the SGLT2 inhibitors, but we don't have the same treatment options for HFpEF that we have for HFrEF. To me, I think making this available to our HFpEF patients, with, let's say, for lack of a better term, the endorsement of the FDA by expanding its label makes sense.
Really well said, Bill. John, and so your vote is yes, I assume, Bill.
Yes.
Ooh, that puts John in a very difficult position.
And it's a position that I am more than happy to accept in this case. So I will vote yes. And I vote yes for the reasons that both Orly and Bill gave. And also to add that, especially in the context that this is a label extension. This is not a new clinical, drug entity that we don't know its safety profile and we don't know the other things, aspects of this drug. So what we're really looking at is there potential for benefit in this label extension? And I certainly, even though the interaction effect was not positive for the primary endpoint. You're right, it's 0.12, but the cardiovascular mortality interaction effect was significant. And so here we have that kind of signal. We have such a marked change between the two programs in terms of their event rates and other things, such that the patient population in Russia, Georgia, as you alluded to, Chris, I think these countries would have been shut down in any other types of monitored program. You didn't see changes in potassium. You didn't see changes in blood pressure. These patients were effectively not getting therapy. And so when you looked at the patients who were getting in a randomized manner within an area and a healthcare systems that we understand, it showed a definitive benefit. So I would have voted yes. And I know Peter will never speak to me yet again.
The things you have to discount, again, I see both sides here, but the things you have to discount in the study are not just the effect of the area of Georgia, right? You have to discount that the benefit is less and less as you get up into what we might call real HFpEF, right? I mean, the
Well,
benefit.
and that's
So,
a
I mean,
great
there's more than
thing.
one thing that you have to discount to say this is a treatment for all HFpEF patients.
Well, that's a great theme we're going to talk about in our next round.
Oh.
But
Let me just, Chris, can I just
yeah,
bring one more point in? And Orly pointed this out. It's not just the design of the trial had an issue that allowed for inappropriate patients to be easily entered, but there was the conduct of the trial. And that was known during the study that these patients had a very low event rate. You know, in iPreserve, when we thought the Russian patients were being enrolled too easily and we were worried about it, we capped their enrollment. We stopped it. And as it turned out, we didn't have an issue in terms of event rate. So I'm not sure how to look at the notion of saying that the trial conduct, unfortunately, because of some issues relating to the NIH, really damaged the ability to see what the effect of this drug really was. So that's I'm not sure that pulls along the idea of approval. At least it doesn't for me.
well, as they say, it is what it is. You know, I don't think the trial would have ever gone to Georgia and Russia if enrollment in the United States was robust, and that's one of the big problems that we're trying to address in the collaboratory. And the other thing is that the monitoring strategy in NIH trials is allowed to be less robust, and so the Data Safety Monitoring Board got was late. The patients were already in and randomized before they could start figuring out that these were low event rate patients and likely didn't have heart failure that were entered into the trial. But let's move on to PARAGON-HF. This was a program, a really important program that came to the advisory committee, did not meet its primary endpoint nominally with a p-value of 0.6, but yet received a overwhelming endorsement from the committee, 11-1, and a label expansion did occur with this drug. What do you think was different? We'll go in the same order. Peter, why a label expansion? Why were people able to take one trial with a p-value of 0.6 and say that's enough evidence?
Well, this one I'll say I would have voted yes on. But the reasons why, first off, it came close. It was a big, well-done trial. They learned from iPreserve and from TOPCAT important lessons about enrolling an appropriate population. And so they were very cautious about what they got. They then did their follow-up and came very close to the primary outcome. Interestingly enough, this 0.06 did involve the use of adjudicated data for heart failure hospitalizations and cardiovascular deaths. And what became remarkable was the data that showed that about 500 events were not accepted by the adjudication committee as being worsening heart failure in one form. Now, the committee used a granular definition, series of definitions that required specific criteria. Dr. Teerlink will talk more about that later, I'm sure. But the investigators were not required to do that. So therefore, perhaps they had a broader view of worsening heart failure than what the committee did. And when you then take the investigator-reported events, you now cross statistical significance and you get very close to what the original agreement with the FDA was. It's interesting. There was a one-tailed p-value that was also part of, I think, the initial agreement. But even with the two-tailed p-value, when you look at the investigator-reported events, they are, you then cross into statistical significance. If you then expand the endpoint a little bit with the outpatient events, then maybe it gets a little stronger, but you have reached statistical significance by using the investigator-reported events. And there was also, Chris, you may want to go after this later, the look that the FDA suggested as a proportional contribution of heart failure to an event that was not considered to be heart failure. And this involved a readjudication by some heart failure endpoint mavens. And once again, a series of findings were shown that, again, moved in the direction of support for sacubitril valsartan. And the last thing I think is that, and you indicated this going into it, that this is really ended up being an expansion of the indication of sacubitril valsartan, that a drug that the FDA was comfortable with, and that then moved out of having a strict EF cutoff at 35% to be higher. So I think for all those reasons, I thought when you look at the totality of the data, there was a lot there, and I thought there was benefit.
JoAnn, you never agree with Peter twice.
No, I can't.
But today I do. I think, again, I think that while patients with HFpEF don't have a lot of treatments, I'm not sure that means we want to approve something if we're not certain, because other treatments come up like the SGLT2 inhibitors, and maybe something else will come up. And so, but you don't ever take them away unless some unsuspected safety issue comes out. So, but I agree with Peter. Also, the point that he made, I think, is that is how are endpoints adjudicated? Are they face-to-face committees? Are they online committees? And I'm biased by the face-to-face committees, but I think they sometimes do a better job than online going in where things just happen very rapidly. So this issue of changing, this was a very large number of endpoints that were changed the endpoint from investigator. And usually I don't remember the exact percentage, Peter, you may, but usually nowhere near this many of the endpoints are changed from the investigator adjudicated endpoints. This was a very large number.
25%, I think.
That's a huge number compared to what is usually done. So that's what influences me a little bit here for a slightly different reason. I think probably there was enough data here to really think about this. But I would argue with one point that Peter made and someone else made on the previous discussion is I think just because something is an extension doesn't mean we should have, I think, less criteria. The safety issue aside, and safety is important, we have data about safety, but is it effective or not? I think that should be the primary thing. And so you leave I think on both of these discussions, there is uncertainty. But I think the data is better enough here that I would have said yes.
Fantastic. Orly?
I am 2 out of 2 voting yes. So I'm going to agree with what's been stated so far, and exactly for the reasons that have already been stated. And not much to add, except that in addition to spironolactone, sacubitril valsartan also has data to suggest that the benefit is more pronounced in individuals with an EF that is below normal. So from that standpoint, I think a story emerges that at least for neurohormonal agents, that systolic dysfunction does appear to matter and may be an element that could be amenable to treatment, at least with sacubitril valsartan and with spironolactone.
So while there's not an efficacy cliff as you go from low EF to high EF, there does appear to be a cliff on the mortality signal. Bill?
Yeah, no, I would vote yes as well. I'll make a couple of points. One, I think we have to not be so focused on a fixed p-value of 0.05. This has become sort of the coin of the realm for success or failure in a clinical trial, but it really is all about, uncertainty, right? And a p-value of 0.06 versus 0.05 means that I'm just 1% less certain than I would otherwise be if that p-value were 0.05. It's a very small incremental difference. And when one looks at the totality of data and balances risks versus benefits, and then, one needs to balance the degree to which one is willing to live with some uncertainty. I've seen very few clinical trials that are certain, right? There's always some degree of uncertainty, more or less. So, here I thought the degree of uncertainty was relatively small. We quibble about a p-value of 0.05 versus 0.06. If that's what we have to quibble about, we're probably, losing the, what do they say, the forest for the trees. So that's one point that, that I would make. The other thing, I do agree with Orly. It appears that neurohormonal inhibitors and antagonists exert a greater treatment effect in patients with reduced ejection fractions. And perhaps our definition of a reduced ejection fraction needs to change. We use cutoffs of 35 or 40%. Maybe it should be 50 or 55%, as a cutoff. And the more one gets to a normal or toward a supernormal LVEF, the treatment effect of neurohormonal inhibitors and antagonists seems to diminish. And I will just contrast that with what I think is the case with hemodynamically active therapies for heart failure, such as pulmonary artery pressure guided heart failure care. JoAnn's done a lot of work in that area, which seems to be as effective in true HFpEF populations as it is in patients with any degree of reduction of LV ejection fraction as well. So, I think that EF might matter here a bit.
And maybe there's also an upper limit, like you're suggesting. I think all of you suggested that something above 55, maybe there's attenuation. We've talked about cardiac amyloid and things like that. John, you going to be the consensus or no?
We're going to make it unanimous, buddy.
Wow. Okay.
So I'm going to go yes on this one as well. And as Peter alluded to, I think this trial is a bit of an outlier in terms of its the endpoints in the adjudication process. And it was rather striking how many investigator-reported events were thrown out. But that being said, when you looked at the investigator-reported, the adjudicated, the probabilistic analysis, and the sensitivity analysis, all of those rate ratios in terms of the beneficial effect all centered around being between 0.84 and 0.87. So regardless of how you looked at it, the observed treatment effect was similar. Whether it was 0.014, which it was with the investigator reported, all the way up to 0.059, depended on how many events you had, not necessarily, the distribution per se. So that's actually fairly compelling for me to say this is a real benefit. And in the context of agreeing with what JoAnn said in terms of we shouldn't change necessarily our efficacy requirements when we're doing expansion of label, but it does liberate us a little when we're looking at the benefit to risk, because we already have a good estimate of what the risk is in general. Obviously, HFpEF patients may have different comorbidities and different balance of comorbidities than HFrEF, but nonetheless, we already had the largest heart failure trial ever done in PARADIGM, where we saw a very good safety profile with sacubitril/valsartan. So anyway, so I'd vote yes, and am happy to give this agent to my HFpEF patients without supernormal EF.
Well, can I make one more comment on this?
Yeah.
One of the concerns about data which isn't certain is that in HFrEF, we built one therapy on top of another. And when one therapy is approved with a strong recommendation, then it's required, if tolerated, for subsequent studies. We do have some data in HFpEF, but we don't have the same, okay, this is strong data, so everybody needs to be on this before you start this. So we don't have the same idea about building therapies like we do in HFrEF. And that's one concern, I think.
That's a really good point, because they're all sort of coming out late in our development experiences, and they're coming out with some wins, and but haven't had time to use them as background therapy.
Chris, I might add, I mean, this is a great role for our guideline writers, right? To try to help order these and make some recommendations, perhaps based on the strength of the data, about what to use first, right? So if we think there's more uncertainty with spironolactone than we do with an SGLT2 inhibitor, the SGLT2 inhibitor might be used first, right? So I agree with JoAnn. We do have to think about levels of evidence very carefully, and make sure that we're making, I think, rational recommendations to ourselves and to other clinicians about, what the, sort of ordering of these therapies and what, represents, optimal guideline-directed medical therapy in this population today.
Very well said.
Chris, just one other point. This percolated through a couple of the statements that people made, and that is, what about this higher EF group, where the signal seems to certainly attenuated in the benefit that we saw with spironolactone in this trial, also with sacubitril valsartan. It's true to some extent with empagliflozin, maybe a little less so with DAPA, but that still remains an area in that higher EF, that really normal group. Who those patients are, in my mind, do they really have heart failure, or do they have some other abnormality? You alluded to amyloid as being possible, and that certainly is true. Some trials are now going to a lot of effort to make sure amyloid is excluded in this population, but that is a bit of a frontier that we still have.
Yeah, maybe the trials that are trying to maximize signals will take a high level cutoff on EF so that it could drop into a label. I think there's been a struggle about EF cutoffs in labeling. I was actually in favor of an EF less than 55 for this indication, but it wasn't studied that way, nor was that the split was at 57. So that's, what clinicians are going to measure 57. Let's go to the last AdCom that we had. This one is fresh in many of our minds, perhaps more controversial, with omecamtiv mecarbil indicated for patients with heart failure and reduced ejection fraction, coming to the advisory committee, which in and of itself is a decision that's made by the regulatory agency. Whether something comes to the advisory committee or not means that there probably is some need or want for some external opinions and advice. And in this presentation done by the sponsors and the FDA, the vote was unfavorable, 3-8, and a lot of issues came up though about development. I mean, there were just an amazing number of issues, whether a large subgroup could stand by itself, whether a phase 2 is an independent trial as a confirmatory trial for phase 3, whether the intermediate endpoints in heart failure are good enough to stand as a second confirmatory trial, and some, I think, general misunderstandings about the data in general when it came around to the heart failure events and safety. But a lot's on the table here, and we'll start with Peter, who is sitting in Rehoboth, and I don't know what he's going to say.
Well, Chris, what you sometimes see the congressional committees, and they say, "I cede my time to," and then they designate someone. So in this particular circumstance, I'm going to cede, if you don't mind, I'm going to cede my pole position here to Dr. Teerlink, because I am worried that the atmospheric river is going to wash him out before he gets a chance to speak. So can I cede my time initially to Dr. Teerlink and then come back a little bit later?
Yes, but if he takes all your time, you're done. John, go ahead. I mean, John has a lot invested here, so I wanted to.
Well, yeah, and I think, as full disclosure, obviously, I've been involved with this development program for 20 years and was primary author on multiple papers in this regard. I think there were a number of general issues that came up from this AdCom that have kind of brought to bear. One of which is, I think it made very evident that there needs to be representation of the heart failure community on AdComs dealing with heart failure agents. It also revealed some of the limitations of the Zoom format. There was clearly less discussion or interaction of members. There was no time for sponsor responses to questions, even when additional analyses were requested. There was no time allocated to that being given. And then there were patently false statements that were repeated and then became truth during the course of the AdCom. So those were some of the general things. Also, while the vote was 3-8, it was 3-4, and then among the 8, 3 of those 8 said, well, if the question had been a little different, I would have voted for it. So there was also some challenge in this setting how the FDA frames some of the questions as being absolutes as opposed to allowing some of the nuance that actually the sponsor tried to present. As many of you know, the trial overall had a positive primary endpoint. And so it met its primary endpoint with a p-value of 0.025 and 8% reduction. The sponsor went to the FDA and said, it's an overall positive trial, but we actually think it's even better in lower EF patients. So we'd consider just having it in lower EF patients. That discussion, despite the sponsor saying that's where they wanted to go, was not really embarked upon during the meeting. So there were a number of things that emerged from this that I think were challenging. And there were also a request by the FDA to have the committee members deal with regulatory issues that I don't believe any of us would have been qualified or educated enough to deal with. So, I certainly, even though I studied it, am not up to speed on what kind of therapies would require companion diagnostic device. And in terms of what is considered substantial and sufficient evidence, the FDA outlined their own draft document that I'm not sure everybody on the committee had time to read or take into consideration. So there were many aspects to this AdCom that I think did this particular proposal a great injustice, especially since this agent has the potential to really help and address a major unmet need in the heart failure community.
I think what you got most of it well said, and I think what John is saying is opportunities here for maybe making things better, so looking at things differently. JoAnn, you've been involved in this process for a while.
I haven't had a chance to read. This was very complex deliberation, as John said, and I haven't had the chance to read the transcripts yet. So, and I also have done a very minor amount of consulting for Cytokinetics, so I should disclose that. But to me, it was a positive trial. The effect size was very small, but it was a positive trial. And I'm not sure, John, if they asked for a separate conclusion, but to me, it's the job of the FDA. And that's what I said. We will approve you if you have a positive trial and we don't see any glitches in that. We will approve you for what your primary endpoint was. And then to me, sort of a corollary with what Bill said earlier, it's the job of the guidelines committee to say, should you use it or when would you use it? But to me, this was a positive trial. And so, again, I haven't had a chance to go through all the weeds, but on the surface of it, I would have approved it, saying you had a very large trial. There were no safety issues in this specific trial. There is some supportive data, and it was a positive trial. So
I think something that John mentioned is absolutely key, which is an unmet need. So while, yes, we have a positive trial, period, that should have us all at hello, right? The fact that in addition to that, we don't have a lot of options for severely ill patients with heart failure on the lower EF spectrum, whose therapies may be really limited to things that are anecdotally used, such as milrinone, or advanced therapies for which a lot of patients may not qualify, such as invasive therapies, ventricular assist device, or cardiac transplant. So short of those, there are not a lot of options for this particular group of heart failure patients. And this is where the importance lies in providing something, and an option besides ones that have either not been studied appropriately or ones that may be limited in terms of access.
And so, Orly, you would be in favor of, while the trial was overall positive, I think people were concerned that that signal, while significant, that strength of that signal was more maximal in the low EF. Would you be in favor of a restricted indication in that low EF subgroup of the trial?
I don't think the indication should restrict it. I think the clinicians and, again, guidelines should weigh in and provide more input on specific clinical scenarios that would lend themselves well to the use of this drug. So I would hesitate to put a limit on the label itself.
Thank you. Bill?
Yeah, well, first of all, I have no conflict of interest here, and I want to commend the study sponsor for actually going into these discussions with FDA and an advisory panel, looking for let's call it a high responder group or a higher responder group, because while I agree with the comments that JoAnn and Orly have made about p-values and the positivity of studies, I do think it's important, again, in looking at the totality of data, to consider the clinical meaningfulness of the effect as well. And whether that be taken on by an advisory panel or a guideline writing committee, it's something we have to think about here. So the fact that the study sponsor looked at subgroups, particularly, this sort of higher risk subgroup with fewer options for treatment, I think was a terrific thing to do. So, whether the label speaks only to that subgroup or to the whole population, and the guidelines, help recommend which patients might benefit most from it, there does seem to be a potential role for this agent in the treatment of heart failure patients.
That's really well said. I mean, I think we pre-specify subgroups, and then we test for interactions. And the overwhelming majority of the interactions, don't meet our criteria, what is statistically significant. In this case, this was a very robust interaction. And I think if we're going to test for interactions and you get something really robust, not like a p-value of 0.1, then it does have meaning, and I think it can help amplify and understand a signal. Well, we've got Peter. We get a little time. You get a little time.
Okay. So, moderator O'Connor. Let me. I'm going to be the outlier again here. I guess I have to be. But within the briefing document, I think the comment was made, I just can't quite find it looking through here, that at an earlier meeting with the FDA, Cytokinetics was told that the trial would have to reach, sorry, Bill, to get onto a p-value again, but it would have to reach the statutory stated approvable value, which would be, I think it was 0.0025. And so this was one of the statements in the briefing document that sort of led off what was a pretty harsh briefing document. And I guess what I would ask people is, what about that? Because we used to hear that for many years about you're required to have 2 clinical trials and at a statistically positive level, or one that was very, very statistically positive. And the FDA's contention then was that this trial did not reach that statutory limit. And I think they then said, well, the key secondary, I think the first secondary was cardiovascular mortality, and there was no benefit really there. And then that put a blocker on looking beyond that. So I'm trying to, I tried to come to terms on this particular study when asked in a sort of minor consulting role earlier before the advisory panel. I said I thought the drug would go through, in part because of the experience for Sequat. So let me just bring up then those 2 issues and ask my distinguished colleagues what they think. This statutory requirement that the FDA has said a trial should meet. And I think all of us may have been in those meetings where we were told this is what it's going to be. And if your trial is not going to reach that level, well, that will be a problem. We'll look at the totality data is the fallback. That became limited a little bit by the cardiovascular mortality signal. But then that is the first issue that I would ask. I'm wondering what people think about that in terms of going forward.
John?
Yeah, so if I may clarify, what the FDA had said was that if the single trial, that if you hit 0.0025, absolutely, then it would get there. If you went less than 0.05 and your cardiovascular mortality was not bad and trending toward positive, then that would count. And so and your analogy to Vericiguat's very salient here, because p-value of GALACTIC-HF was 0.025 with an 8% reduction. And Chris, you can correct me on this, but I think Victoria was 0.02 something as well, with a 10% reduction in their treatment effects. So very similar treatment trials. And so it's strange that in the committee that the trial was penalized a bit because it showed that actually this agent that improves cardiac performance didn't change cardiovascular death. And it showed that it was very safe in terms of its mortality signal. And yet that seemed to not work in its favor. And I think JoAnn had a comment.
No, not to take the focus off omecamtiv, but you can ask yourself if we need one trial that has a trend toward positive cardiovascular mortality that's significant, or 2 trials if it doesn't, then how many do we need if we're going to do retrospective evaluations of initially negative trials? Is one retrospective evaluation of a negative trial adequate? Which is what we've said, right? Twice here. I think we have to be careful about how we think of these things. Sorry,
You're
I couldn't resist.
Yeah, you couldn't resist, JoAnn. But I think what I think we didn't get on that track. I think what John put is that a number of diabetic drugs were approved because with guidance that the upper level of the confidence interval around mortality fell under a range, whether it was 1.3 or 1.1, and here the upper level of the confidence interval in mortality was less than 1.09, I think. And so I think reinforcing what John said is the safety of this drug, but tough decision. The advisory committee is only advisory, so I think the fact that there was healthy debate and there are still some dangling participles around some of these concepts that were allowed to stay in, as you highlighted with some of the limitations of the current format of the AdCom committee, to stay in play, it will be sort of re-reviewed by the FDA. In my opinion, I know that a number of people are making communications to the FDA to do such. Peter?
So I think the other issue that came up, and for TOPCAT and for sacubitril valsartan, I don't think the FDA was finding that there might be a safety signal. But the FDA did become, Chris, you know this very well, very involved in the notion of whether there was a safety signal relating to omecamtiv. Now, there is no safety signal that one saw regarding either adjudicated myocardial infarction or unstable angina events or those that were reported. But there was this signal, there was this concern about the drug accumulation and the adjustment for dosing. And that then, I think, presented another lens that they saw the drug through. And it did seem like, looking through the briefing document and then also some of the discussion that day, it was an issue that they would not let go of. So let me just bring that in, because that is a little different than what we had in the other trials. Concern about the safety of the drug, even though you had an over 8,000 patient trial with no appreciable increase in ischemic events of any kind. John?
Yeah, I mean, I don't know how. Yes, there was a lot of perseverance on that. There was also some discussion of how the sponsor was actually asked to present a no drug monitoring model, which they did, and then they were criticized for putting that forward. The intention was always to use, some degree of initial therapeutic drug monitoring with the initiation of this, which is what was done in GALACTIC-HF. And even despite the CYP variants and everything else that existed in that 8,000 patient trial, there was no bad signal. And when they did the final risk to benefit ratio, they forgot to include the fact that omecamtiv mecarbil significantly reduced the stroke risk with over 190 events in the trial. Mm-hmm. So if you look at the overall MACE, the extended MACE, the heart failure MACE, there is actually, once again, a 0.01 benefit in terms of omecamtiv mecarbil. So I agree, the briefing document and then the discussion was really driven by certain issues that I'm not sure were as constructively discussed or is relevant to the overall discussion.
Well, let me just bring in the other point, John, that I mentioned and you were caught up on also. And that is the idea that vericiguat, which would be another drug in more or less the same space of advanced heart failure patients, went through. So was it that there was not a detected safety signal that the FDA was concerned about? Because as we looked at the risk ratio, at least for the primary outcome, p-value, et cetera, were pretty similar.
So there have been multiple changes that have gone on, at the FDA in terms of people involved in the different programs and things. There have been other things that have occurred, such as with the Alzheimer's drug. So there's a change in the environment there, for one thing. The second thing was, and Dr. Stockbridge led the meeting off with this, saying that, well, with vericiguat, there was a non-significant 7% change in beneficial change in cardiovascular death, which is a p-value of 0.12. And omecamtiv mecarbil did not have that. It was neutral. It didn't save lives. It didn't, hurt people. So that was the distinguishing characteristic that Dr. Stockbridge started the meeting off with, that kind of difference, to try to actually take vericiguat off the table as a comparator.
Yeah, I think that's...
Is that fair, Chris?
I think that was accurately described. Well,
Or was the difference simply Chris O'Connor?
No, I don't think it was Chris O'Connor. But look, we've brought up a lot of important issues today.
I wasn't allowed to speak, folks. I was not in the meeting
I know.
At all.
You are a government agent.
I'm a government employee. I couldn't do it.
And maybe that's something we should look into too. I'm not sure why government employees in different branches can't speak.
I meant for Victoria, Chris.
No, I know. But
Well, that's why I gave John my time.
and John used it well. John used it well. You clarified a lot of good things, John. Thank you. But this panel has raised a lot of issues, amongst all three AdComs, and we've come up with a few important, I think, suggestions, some ways that we can maybe improve the ecosystem. That's the goal of the Heart Failure Collaboratory. How can we improve the ecosystem? But I just want to personally thank each and every one of you for taking time out today. JoAnn from sunny Florida there with the palm trees and making us all envious of where you are. But for this component of Heart of the Matter podcast and collaboratory, I want to say thank you. I've learned a lot, and I think our audience has too. So have a great day, and we'll talk again. Thank you.